Light is just straight in the eyeballs. Okay, excellent. Good morning. Thank you so much for having us on this last day of a fantastic conference and for attending this talk in particular. We are very excited to bring you CFPC Learn in the Clinic. And if you didn't look at what this is, we do hope for a bit of audience participation, not quite as much as like choose your briefs and things, but we will be asking you what you want to learn, so don't get too comfy. But yeah, we're here on Remembrance Day, and so just so everyone knows, at 11 o'clock we will be taking a pause for a moment of silence, so just be prepared for that. My name is Jessica Kirkwood. I'm a family doctor in Edmonton, Alberta, and a very proud member of the peer team. And I do take money for speaking and travel expenses and things like that, but I don't have any association with pharma, and I have nothing to disclose that would affect what I'm going to say today. And I'm a salaried employee at the U of A.
I'm Dr. Jennifer Young. I'm a family physician in Collingwood, Ontario. My disclosures would be that I do get speaking honorarium for the Ontario College of Family Physicians, and I'm a part-time physician advisor at the College of Family Physicians of Canada.
And I'm Emily Bresky. I'm a family doctor in Ottawa. I also work part-time with the CFPC as a physician advisor and also a member of peer. Nice to meet you.
All right. So thank you for coming to our waiting room. These were strategically placed here, I guess. And we're in the clinic, and we're going to be meeting some virtual cases that the peer team has put together, where when I practice, I finish a visit and go, I wonder if I did that right. I wonder if I did what evidence there is out there shows. I wonder if who knows? I don't know. Off we go to the next patient. But today, we get to meet patients and we get to work through cases and find out how we could do our best version of evidence-informed practice. And so that will be what we're doing. And this is our very brief day. We know that very few of us go to work and see 9 patients, but that's what we're doing today. And in fact, we're cutting it even shorter. We're actually only seeing 3 of these patients. But I'm responsible, and actually, yeah, and we do such good work that each of us only takes 1 patient. So, I mean, if you want to practice excellent care, you should see 1 patient a day and do it really well, and that's what we'll do. So the first 3 patients, we've got Ken, Naomi, and Mr. Ramakanta. Those are who you're choosing from. So take a look at those cases, and we're just going to have a quick vote on who we should see. So, who would like to see Ken as the case? So we're going to just do a show of hands. Oh my goodness, there's Ken. I will say that Ken is an excellent case. I do this every time. I tried at Pipe, I really tried to start like a vote for Ken campaign. Very few. Who wants to meet Naomi? Oh, you always do. Yep. Yeah. Hint, or a little spoiler alert, there's not a lot of evidence, but we'll do our best. And who wants to meet Mr. Ramakanta? Oh. I think it was still Naomi, wasn't it? What do you guys think? This light is blinding. It is. I think it's Naomi, and that's okay. She's lovely, but I don't know anyone that looks at their schedule and is like, oh, good, I really want to see this lady and talk about if it's safe for her to drive or not. That's not a... Okay, hold on. I should just be able to... Am I doing this wrong? Oh, how do I click? I'm an Apple girl. Sorry. I don't understand this ThinkPad. Beautiful. There she is. Oh, okay. And now I'll just spacebar it, right? We're laughing. Okay. Yeah. So, I mean, I think we picked this case because this is something we dread. And this is definitely one where it goes, I don't know, did I do that right? Did I not do that right? We try our very best, but this is not a visit that we look forward to in any way. So, dear Miss Schiff was recently discharged after a hip fracture. She'd spent some time on the geriatric rehab unit. And she comes in to say, you won't believe it. It's bad enough I get a hip fracture, and somehow they thought my brain and hip are connected. They asked me to draw clocks and other things. You're like, here we go. Next thing you know, they tell me I have dementia, and I shouldn't drive until I see my family doctor. Here's this giant stack of papers and forms that they want you to fill out and look at. I have a few more, too. In my patients, there's always some sort of like mystery stain on every page that I don't like to think about. So here we go. She brings in her mocha, and we take a look at it, and we can see that, you know, like we're starting out okay. And one thing I do think I would love a T-shirt with like all the various forms of clocks on a mocha. Gosh, they're just beautiful. Sometimes you squint. What's that? What is? I don't know. Is it a happy face? But we see there at the end there that she does. We know that she has some arthritis, so that would impact her writing. But her score is about a 22 out of 30. Okay, so if we had more time, we'd pause and answer all these questions. But we're just going to answer them for you. But you know, her true or false that her score shows cognitive dysfunction. She can't drive. Gosh, I wish it was that easy, right? We could just go, well. No, we need a bit more information, hey? So in order to diagnose dementia, we do need that cognitive impairment as well as a reduced level of function due to cognition. And though we have a 22 out of 30 MoCA score that does show cognitive impairment, we need to know how she's functionally managing in terms of her ADLs as well as her IADLs. And there was a Cochrane review that looked at just the MoCA alone to say, can we make this call or not based on this tool? And really, we've got good sensitivity that we can rule out dementia if that score is normal, but not as great if the score is low to just say, hey, we've got this diagnosis and we can move on from here. We need a bit more info. So, I love this. Can I ask Steve how things have been going at home? She's like, yeah. Sure, of course. Guess what? Steve doesn't say a word. Never does. Doesn't for the rest of the case. We just speak over Steve. But gosh, she's there just providing an arm of support. But she goes on to say, I'm doing everything like I used to. Sometimes I need a little help to get dressed due to my arthritis. What I really want to know is, when can I get back to driving? Of course. So what would be enough to tell us that she can't drive anymore, that she can't dress on her own due to her cognition, she can't cook on her own, she needs help to cook and take her medications, or that she has neck osteoarthritis and she actually isn't able to shoulder check safely? What would be enough for us? Well, there's three things there that would be enough. And I think this is one of the key points in here is what would lead us to say that, yes, there's a contraindication to driving. And it would be 2 or more IADLs, and so you can look at that shaft mnemonic like shopping, housework, hobbies, accounting, food prep, telephone, tools, transportation, or 1 or more ADLs, so the always pleasant death mnemonic there. We love our mnemonics. Dressing, eating, ambulation, toileting, transfers, and hygiene. So that would be enough for us to say. So we do have some questions, you know, is it due to arthritis? Is it due to cognition? But that's something to remember when we're looking at how much impairment is enough to say, hey, it's not safe to drive. And we need to remember that driving itself is an IADL. And when we talk to her a little bit more about how things are going, has she gotten lost? Has there been any fender benders or accidents? What about some tickets, particularly like, driving a little slowly? Are people commenting on her driving? So we don't have a ton of evidence to look at the validity of family members' worries and things like that, but this is absolutely a place where Steve should pipe up, or we should try to have a conversation with somebody that knows her well. To get that collateral history. All right. In terms of like what we should use, really the CMA guide just recommends some sort of cognitive assessment, so a mini mental, Trail B, clock drawing, but really no specific cutoffs in terms of what would indicate that she couldn't drive. And really clear abnormalities would be contraindications, but borderline results may require some on-road testing, as we know, and we can kind of repeat that as things go. And then in particular, when we talk about her inability to shoulder check safely, that would be one where, that's quite concerning, and we need to be able to be aware of our surroundings to drive safely. And then, and other things that we know come into play when we're looking at this assessment. All right, so in this visit, we can confirm that she can do all her ADLs. They've been helping a bit with her IADLs, but we really don't know if that's due to cognition. And then there's a few things that she's struggling with, again, due to her arthritis. So it sounds like you might have some mild memory issues. Did they do any other tests? Because we have this giant stack of papers with mystery stains. So yes, they did, and here they are. I'm not sure what this trail thing, I'm not sure why this trail thing's relevant. So I, in preparation for this case, wasn't as familiar with the Trail B. So that's an example. It's basically just an extended version of what we see on the MoCA. And so in her case, we've got kind of what happened there. And things that we want to note are that it took her 4 minutes and 22 seconds and that she had 3 mistakes on her Trail B. So what does that mean? Because I again, wasn't as familiar with it. So what isn't correct? So this test can be used in isolation. I think we've already kind of hinted that we need to do multiple assessments. A score with 3 errors is a fail, or a score of 4 minutes and 22 seconds is a pass. The incorrect thing there is that she took a bit long on there, and so there's kind of a rule of 3s with the Trail B. So anything longer than 3 minutes or 3 or more errors would be considered a fail. And that if we're within the 2 to 3 minutes or 2 errors, that's kind of a not too sure. And if she's under 2 minutes and has only 0 or 1 errors, then that would be a pass. I thought about doing my own Trail B, and then I just realized I don't actually want to know what that result might be. Ignorance is bliss. But not today. We're learning a lot. I think we know this. Another little uncomfortable moment was when I was thinking about my own 75-year-old mother who does a lot of driving of my children, and I was reading this case, being like, oh gosh, I don't know, is that safe or not? But I hope so. Maybe I'll Trail B her one day, but not until those kids get to their extracurriculars. But we do know that people tend to live their driving expectancy, and most aren't planning ahead. It's so hard being a family doctor. We're supposed to predict the future and plan for the future, and also manage what's happening. And there's all this past stuff coming up. We're incredible at what we do. I just wanted to throw that in there. All right, so yeah, I'm sorry to say that it does give us a bit of an idea of how safe you'll be on the road, and actually in this case, it was a pretty clear fail. I wouldn't say that, it was a clear fail, but I'm definitely worried, and that's where I always, it just comes from concern, right? I'm concerned about your safety. This makes no sense to me, of course. And we just can, again, talk about what these tests mean, what they're telling us, and then just a little shaming, guilt there. It'd be awful if something were to happen to you or someone else. No, I'm kidding. But really, yeah, we need to try to keep everyone safe. Again, we're family doctors. We have to keep the entire society safe, too. Just like we don't have enough on our plate. All right, well, she's like, hey, I was dopey on meds. Can I just do it again, right? She's scrambling now. This is so inconvenient and such a loss of independence. And so this is fun, because actually in Alberta, where I'm from, it's not a legal requirement, so that just adds in this element of complexity, do you do the right thing, don't you? I don't know, it doesn't matter. Also, we just assume that Albertans are just gonna be I'll self-report when I can't drive, which doesn't happen. But yeah, so in this case, for example, I'm practicing in Alberta, and I'm saying, well, it's not my legal responsibility, but we have to talk about the fact that it's probably not safe for her to be on the road, and also if we wanted to do a road test, that there's an added financial burden to that. In terms of that question about repeating the test, there actually is pretty good retest reliability with the Mini-Mental and the MOCA, and we need to see a change of 5 or more points to say that this was a real impact from her being dopey on her meds in hospital. A bit less data for the Trail B. Okay, so we're wrapping it up. We've got our plan for Ms. Schiff, and it's nice when you make up the cases. You can make them end the way you want them to, right? Isn't that special? So she says, yeah, okay, fine. I won't drive for now. We're going to book a follow-up appointment to repeat the MOCA and the Trail B. Oops, oh my gosh. That's it. So how lovely. If it feels uncomfortable, it's because it is. And this isn't easy stuff that we deal with all the time. And hopefully there's a few tools and things in there that can help. But yeah, thanks. I'm done for the day. This is the best day at work ever. I'm going to pass things over to my colleague and get ready to vote. Get your hands ready.
Thanks so much, Jess. Just want to say we're going to take questions after the 11 a.m. break. So hold your questions, and we'll try and get to those after the Remembrance Day break. So I've got 3 people who could potentially come and see me today. I have Anna Ploidy, prenatal screening, Farah Lowe, heavy menstrual bleeding, and I have Norma Monroe for insomnia treatment. So who would vote for Anna? Okay, and for Farah Lowe, okay, and then for Norma Monroe, insomnia. Okay, that's tight. I think it looks like, I do think it looks like insomnia, but we could maybe vote between Farah and Norma. So between those two, Farah and Norma. Whoa. Okay, I think it's a coin toss. Yeah. And I think it's, yeah. Well, you know what? I'm going to go with Norma. So Norma is, you saw her a couple of weeks ago. She's 78, and she had come to you with about 3 months of insomnia, such that she was not able to do her crossword puzzles, which mean a lot to her. She and her daughter do Wordle, and they do it every day at 10 a.m., and she's just too sleepy to get it done and beat her daughter at it. So she's got controlled COPD. She has osteoarthritis of her knee, and she tried some over-the-counter medications, including melatonin, and it didn't really work. She returns with the sleep diary that you had given to her 2 weeks ago. So I learned a lot doing this. I tried to not stare at the clock when I was doing it, and that's good. This is going to help you fix your sleep. This is what she brought in. So what do we do with this, she says? Well, I'm going to say, well, we'll analyze it a little bit later in the appointment. I have a few questions to ask my colleagues before we get to this. So first question being, this is going to be around a prescription for, there's going to be information around a prescription for sleep restriction. And so my first question to you guys is, what are all the things true about sleep restriction as part of insomnia advice? It consolidates fragmented sleep, it's dangerous, it's more effective than sleep hygiene alone, and it could help stop medications. So the answer is, the only one that is incorrect is that it's dangerous. Sleep deprivation is a process over a period of time, so 6 weeks is about the prescription time that you would be working on this. It aims to consolidate fragmented sleep so that you get that consolidated sleep and enhances the endogenous sleep drive. An example of a protocol, and I'll be talking more about this a little bit later, is you pick an average day, calculate the total sleep duration that they would normally have, you set a wake time, count back, and then that would be their sleep initiation time. So you eliminate naps if possible, and if it's not possible to eliminate naps in those first weeks, that they can have one between 1 and 4 p.m., a maximum of 45 minutes. So that's just, as I say, we'll get back to more on that. So looked at sleep restriction compared to sleep hygiene alone, 7 RCTs in a systematic review, and sleep efficiency improved about 10% in the people who were given sleep hygiene advice as well as sleep restriction, going to about 85% versus 70 to 75% in sleep hygiene alone. And then that sleep latency delay in getting to sleep was 6 to 19 minutes faster than control. Harms, there was only one high-quality RCT that actually looked at that. Motor vehicle accidents, there were no differences. Sleepiness in those initial weeks, no difference. And injuries, in fact, slightly more in the sleep hygiene alone group, 14% versus 29%. I would say the numbers were very small for those accidents anyway. Stopping hypnotic medications, 50% with sleep restriction therapy versus usual care, 15%. That's a number needed to treat of 3. Love that. Insomnia CBT. So that's that insomnia, it's a type of CBT that's focused on insomnia. It improves sleep efficiency, about 10%, as we talked about, versus the Z drugs, 5%. Now, these are indirect comparisons. So, Norma, that sounds complicated. It makes a bit of sense, but really, are there no pills that can help me right now? So, yeah, there are, but pros and cons. Older, and they get those problems with sleep pills are accelerated when we are older. So these questions. Z drugs, they're effective with minimal side effects in RCTs. Placebo response is about 25 to 75% that of an active medication. Trazodone is effective and safer than other sedative hypnotics. Benzodiazepines result in more falls than other medication classes. Benzodiazepines have a clear association with dementia. So our answers there, the first two are correct. Z drugs are effective with pretty minimal side effects in RCTs. They fall asleep faster, about 28 minutes more sleeping time, but there's no change in perceived sleep quality. There are the few side effects, the classic tinny taste in your mouth. There were inconsistent effects on verbal memory or attention, so those sort of measures of cognitive function. And there were no differences in falls found in these, and no differences in falls. So there are few studies, unfortunately, in older patients, but one Cochrane review had found that there were no significant adverse effects over 1 to 6 months. So placebo, it improves, just being on a placebo improves your sleep, both subjectively and objectively, interestingly. Measures between 25 to 75% of that of the active medication that they're compared against. So for an example, in one RCT, and this is one that would have been analyzed, and the numbers here the differences are not representative of the meta-analysis of esoplacone, but the total sleep time for the placebo group was improved by 36 minutes, and the esoplacone was increased by 72. So that's about a 30% of the effect of the active drug was seen in the placebo group as well. And you see this in lots of medications that are around subjective symptoms. You'll see it in antidepressants. In the chronic pain literature, you see it as well. So trazodone, it has a small effect, and I know we're seeing it a lot. I know that it's being used and recommended frequently anyway, it's being used a lot, but it has really quite a small effect on short-term sleep quality, and perhaps like 0.3 fewer awakenings. Trazodone, it does not have consistent benefits over placebo. So with falls, there was no difference compared to other sleep medications, but more compared to no medication. This is in retrospective observational studies, so it's a little less accurate than an RCT. And then mortality, which is a bit of a worrisome signal, again, observational versus no antidepressant, 12% versus 7%. So benzodiazepines and falls. Benzodiazepines, indeed, have about a 40% increase in risk, or that odds ratio of 1.4. The long-acting, like diazepam, has a slightly higher risk ratio at 1.8. Oxazepam, lorazepam, around 1.3. But when you compare that to the other medications like antipsychotics or antidepressants, it's in a very similar ballpark, about 1.5 odds ratio for both of those. So switching out of benzo for an antidepressant, you're really no better in terms of falls. Dementia. Systematic review in 2022 of observational trials. There is a weak association between benzodiazepine use and dementia. But when they took out the higher quality studies, they found that there wasn't such a strong, there wasn't an association. So it is unclear if benzodiazepines are a risk for development of dementia, and we're less clear about the mechanism of that. So those pills don't sound all that great. I guess I'm open to something else, and is that what that sleep diary is for? So insomnia CBT, you might ask. It's not possible for me in my practice. I am too busy for this. True or false? Well, I'm going to try and make a case that that's false. So access to iCBT, so insomnia CBT, traditionally those are 4 to 6 sessions with a trained therapist. It's really not accessible for me, I'm sure, for the vast majority of people who are in the room as well. So what we want to look at is there a way that we can do this in a practical way in a family doctor's office? And there's this great study that I wanted to talk about, shortened versions, so 2 to 3 20-minute sessions, have been studied in primary care practices. And I'll just tell you, there was in this group, there were 22 people in the sleep hygiene alone, 22 people in the sleep hygiene plus sleep restriction, and they were followed. First of all, 20 minutes were spent with the study group, 20 minutes in that describing the sleep diary and the process of sleep restriction, versus about 11 minutes in the sleep hygiene alone group. And then that's the study group that they were seeing 2 weeks later, reinforced the process, answered questions, sent patients to perhaps more resources, and then they were followed up at 6 weeks. And the effect in this study was that wakefulness was reduced by half, 50%. Sleep questionnaires, 56% improvement, and better or much better quality of sleep, 73% versus 35%. So 2 times 20 minutes, a process that doesn't have side effects. 6 weeks later, these kinds of effects are possible. So, but she is, in addition to being tired, she's also really worried that this insomnia is going to cause dementia, and so she really wants to fix it. She wants something that's a surefire thing. So one of the components of insomnia CBT, which is identifying those dysfunctional beliefs about sleep, this is a bit more challenging in a time-constrained family practice. And these brief intervention studies didn't include that. So there is some of those dysfunctional beliefs that are explored in insomnia CBT are things like, I need 8 hours of sleep, I need to catch up on sleep loss, there are bad consequences of insomnia on health, it's better to take sleeping pills. So this list is available in a website that I hope many of you have already used, that I use all the time, is mysleepwell.ca. And on that website, there are some great resources. There's also a checklist where they look at these beliefs about sleep, and the person themselves can go through those validated questions around dysfunctional beliefs. And those can be explored if you have the time. It's one of those additional components of the CBT component of insomnia CBT. So we're going to make a plan for Norma. We're going to go back to that sleep diary. So you're going to pick an average day. So we're going to pick Tuesday. And in that day, you calculate the total time that she spent asleep. And then you calculate the total time that she spent in bed. So she was 345 minutes. She was asleep. And she was in bed about 510 minutes. So her sleep efficiency is 68%. And then what you'll do is you ask her, like she's saying, this is really weird. Are you sure this is going to work for me? Seems really different. Sleeping pills it does seem to show, sleeping pills, it can be better than sleeping pills. So we're going to try and teach your body to sleep in bed, sleep or sex. And so you negotiate that rise time with Norma. 5:30 is when she thinks it's pretty reasonable. And in our calculation, she needed about 6 hours of sleep. So you count back. And in some protocols, they'll add an extra half hour. So she goes to bed at 11:30, and she gets out of bed at 5:30. So there's the prescription, is going to bed at 11:30, getting out of bed at 5:30. So these are just some insomnia. The sleep restriction is as well outlined on the mysleepwell.ca site. So she said, oh my gosh, what am I going to do until midnight? So yeah, I know it's a big change. It works. Find some things you need to get done. Get your extra crossword puzzles done. Get ahead of your daughter. Watch TV, not too stimulating. Do a puzzle. But how long do I have to do this before it fixes things? You'll start to notice an increased sleep efficiency in the first couple of weeks. You'll be tired. The first 4 days are usually the worst, but we want to see you in 2 weeks and go over how things are going and see your sleep diary. He says, well, sure looks like I got my work cut out for me, but I'm with you. So that's Norma. So...
Thank you. So we have one last patient. And this time we have the option between Liz Hall, who's coming here because she's worried that she may have C. difficile again, We have Anna Flax, who's coming here to talk about whether or not she does have a penicillin allergy. And Mr. Ramakanta, once again, for the management of congestive heart failure. And we're talking about reduced ejection fraction. Okay, so let's take a vote. Who goes for Liz Hall? Okay, not many. For Anna Flax? Okay, and for Mr. Ramakanta? Oh, I think. Okay, so let's do it again. So between Anna Flax and Mr. Ramakanta, so Anna Flax. Okay, and Mr. Ramakanta? I would say it's Anna Flax, but okay, I'm hearing no boos, so let's go for it. Okie dokie. So Anna is a 30-year-old healthy lady who unfortunately does have seasonal rhinosinusitis. So she comes today because she wants to refill for her fluticasone. She tells you, it's so bad, even a nose spray is barely working. Why do you think of neti pots? And I must say, I had no clue what neti pots were until I started working on this. I don't know if it's because I was in a dark cave, but Jess loves them, so she'll let you know, in case I'm not the only one, what those are.
Not sponsored by Neti Pots, I didn't, but I do. I love Neti Pots. I don't find anything more satisfying than when you get a good saline rinse. TMI, but it's true. But yeah, so if you're not as familiar, there's like the teapot, there's like a teapot version, or like a squirty saline thing that you're just blasting your boogers out. So there you go. You're welcome.
So if you've never tried, go ahead. Okay, so what's true about nasal irrigation? And I'll give you a bit of time to think about it. Hypertonic saline is better than isotonic. Nasal irrigation and nasal steroids cannot be used together. Symptoms improve by about 30%. Nasal irrigation sprays are as effective as rinses, or nasal irrigation sprays are more tolerable than rinses. So indeed, nasal symptoms improve by about 30% with nasal irrigation. And if we look at compliance as a surrogate for tolerability, at 8 weeks, we get an 80% compliance with rinses versus 90% for spray. So spray appears to be a little more tolerable than rinses, even though they are loved by Jess. Hypertonic and isotonic are just the same, so no need to go fancy. And nasal irrigation and steroids can be used together, just not exactly at the same time, but for example, at a different time of the day is just fine. Nasal sprays appear to be a little less effective than the rinses, and while there was some evidence indicating that it may improve quality of life, it's not so clear. So hopefully we'll get some more data for that. So she tells you, well, since we're talking about allergies, my friend, she was just in the emergency room because she had a really bad reaction to peanuts. I had a rash when I took penicillin as a kid, and I was told I was allergic and never ever to take it again. Do you have that on my chart? So let's think about which one of those could be wrong. First of all, a penicillin allergy diagnosis in the chart is associated with some bad outcomes, such as receiving broader spectrum antibiotics, or it's been associated with increased chances of MRSA or C. diff, or up to 10% of the population has a label of penicillin allergy, or 10% of patients with penicillin allergy label can take penicillin safely, or delabeling penicillin allergies is recommended by multiple organizations. So we're looking for the false one, and the false one is that 10% of patients can take penicillin safety, because in fact, 98% of patients that have a penicillin allergy label can take beta-lactam safely, including penicillin or amoxicillin. So from cohort studies, we've come to realize that having that label is actually not benign. So when there is a penicillin allergy label in the chart, patients are more likely to receive clindamycin or broader spectrum antibiotics. They're also more likely to get MRSA or C. difficile. So it's not nothing. And we're talking about a lot of people. So 10% of the population carries a label of penicillin allergy. Because of that, delabeling is recommended, so choosing wisely, the CDC, the King Society of Allergy and Clinical Immunology, and probably many others, do say go ahead and delabel. The question is how to do that. So in the past, when we had a patient who had a diagnosis of penicillin on the chart and we wanted to give some antibiotics, sometimes we'd wonder, what other beta-lactam can I give that has a different side chain? But now that we know that so many patients can actually take penicillin, the question really is, can I just go ahead and give penicillin or amoxicillin? So you tell Anna, okay, so it might help to know a little more. But of course she says, well, my mom said I had a rash and that's pretty much all I know about it. And I haven't taken penicillin since. So which of the following would make this more likely to be a real allergy? So it occurred 5 years or fewer ago, so it was fairly recent, less than 5 years, or she had anaphylaxis, or she had a severe cutaneous adverse reaction, so we're talking mucosal lesions, desquamations, organ dysfunctions, things that you don't want to hear about, or she requires some medical treatments, or all of the above. So it is all of the above. There is a tool that I'll go through on the next slide, a PenFast tool that's been shown to be helpful to figure out which patients are at low risk of having a true penicillin allergy. So a score of less than 2 or 3 has a negative predictive value of 100 to 96%. So it's 100% for 2 and 96 for 3. And that's actually comparable to formal penicillin allergy skin testing. So as we know in medicine, there is never a perfect test. And even patients who are negative after penicillin allergy skin test will still react with an oral challenge. So this PenFast tool is equivalent to doing that. So what is the tool? So you get 2 points if the allergy was less than 5 years ago. You get 2 points if it was anaphylaxis. 2 if you had a severe cutaneous reaction. And then 1 if you needed medical treatment. Now, in order to be considered low risk, at first people were using the less than 3 threshold, now it's more less than 2. So really you're looking at having 0 points or 1 point. So you're looking at somebody who had an allergic reaction a long time ago and may have needed medical treatment. Usually that's using an antihistamine. That's more typically what people mean by that. So anything more than an allergy that happened a long time ago, I went to my doctor, got antihistamines, is not low risk. So for Anna's case, her score is 0, so she's low risk, and she can safely take beta-lactams. Some patients may need referral to an allergist, so either if you're uncomfortable or they're uncomfortable, they can go to get some formal skin testing or some oral challenge. And when there's uncertainty, it's actually likely cost-effective to go ahead and refer to make sure that the label is removed if that is appropriate. So let's talk about different cases. So you may have somebody who had a vague rash as a child, another person who had a true anaphylaxis, so we're talking about urticarial rash, wheezing, vomiting 2 hours after first dose of antibiotic, somebody who had a rash, which could be urticaria and or angioedema and received treatment, but it wasn't a full-blown anaphylaxis, or somebody who had a severe delayed non-IG mediated reaction, so we're talking about the Stevens-Johnson's, the DRESS syndromes, desquamation, organ dysfunction, the really bad stuff. So who's high risk? So somebody who had confirmed anaphylaxis, in which case you should probably not prescribe beta-lactam and refer to an allergist for confirmation or reevaluation. Who is intermediate risk? The patient who had a rash and received treatment, in which case you can refer to skin test or do an oral challenge. Some primary care practices are starting to do oral challenges, so it'll depend on your comfort level. Obviously, if the patient had angioedema, you may be less comfortable than if they just had a rash. So something to keep in mind. Contraindicated, anybody with severe, delayed, non-IG mediated reaction, no more beta-lactam ever. And in somebody who had a vague rash as a child, so this is Anna's case, you can probably just go ahead and prescribe your beta-lactam, any beta-lactam. So you refill her fluticasone. You encourage her to try some nasal irrigation when her nasal steroid is controlling her symptoms. and you reassure her that you don't think she has a true penicillin allergy, and you don't include it in the chart, easier than including and then delabeling a couple of years down the road, and you follow up as needed. I think we're a little ahead of schedule. Sorry.
You got applause. Hello. That was a great choice. Oh, wow. All right. Well, I guess we could probably entertain like one or two questions, and then we are going to pause for a moment of remembrance. But yeah, we'd love to hear any questions. Here, I'm going to move back. Oh, how do I do this? Anna doesn't have the thing that takes us back to the home slide. Ay, caramba. Yeah, that's what I was going to try to do. Well, my tech support helps out. If you enjoy this type of learning in terms of learning about cases, there's a few different ways that you can do that. So we do have a podcast called In the Clinic that these cases are featured on. It's usually about 20 to 25 minutes per episode, and we move through one clinical scenario. Also on CFPC Learn, there's interactive modules that you can do where you work through these cases and you get to answer the questions yourself and get them wrong all the time like I do, or right if you're smarter than me, which is everyone in this room. But you do get credit for both of those things. They're certified. So we're just going to rapidly zip around. But actually, okay, thank you for saving us. We said there's no possible way we'll finish early, and we did it. So there you go. We will now pass things over here, and we'll have a moment of silence. We're trying to get that slide up, but we're having a whole situation here.
I didn't want to make you guys stretch out much longer, so.
It was uncomfortable.
Good morning, everyone. I'm Dr. Leslie Griffin, the chair of the Family Medicine Forum Committee. As you know, today is Remembrance Day. On the 11th day of the 11th month of the 11th hour since 1918, we have paused in remembrance of the end of the hostilities of World War I to recognize all of the losses and all of the sacrifices that have been made by our servicemen and servicewomen, both in World War I and since, and also to recognize all of the loss of human life and ultimate sacrifices that have been paid since that time. We'd also like to take this opportunity to recognize and thank all of our physician colleagues across the country who are currently veterans, who are in active service. So thank you. So, I hope it's close. We are a little early, but on behalf of the College of Family Physicians of Canada and the Family Medicine Forum Committee, we are a couple minutes early. Hopefully this is not too disrespectful to our members in service, but I do ask all of you to rise and join me as we observe 2 minutes of silence in remembrance, lest we forget. Thank you, everyone. Please enjoy the rest of your morning, and thank you guys for the interruption.
All right. Our plan, we had presented our 3 cases, and then we had left this time for questions. So if there are questions, I'll just quickly, the mic is in the middle, so please step up that. I'm just going to quickly talk just a tiny, for one more second, and I still don't know how to use this computer, I'm sorry. Can we just go to just a tiny bit about the peer team and the work that we do. So again, we do have those case-based learning modules that are available on CFPC Learn, but this work is primarily, it's all put together by the peer team in terms of taking a look at the evidence and summarizing things to, there's Liz, she's just back. She really wanted to be here today. She's Elizabeth Hall. For those that aren't familiar, the peer team produces evidence summaries that are available every 2 weeks called Tools for Practice. Those can come directly to your inbox, and we keep them 350 words or less, or else Adrian, our boss, will murder us, and we suffer severe consequences. I tried to squeeze in 351, and I still have bruises from that. Also produce guidelines. If you were here earlier this morning, we talked about our new guideline, which is on lipid management in primary care, that we're really, really proud of. And we have a few more guidelines in terms of chronic pain, opioid use disorder, cannabinoid prescribing in primary care. Why don't we go, sir, go ahead and ask your question, and we'll do our best to answer it and maybe get those slides up after.
Thank you very much. Sorry, I have a question about the driving case.
Oh dear.
So I'm wondering about if you know any evidence around the reliability of the driver's test, because I've been in this situation before where a patient will say, well, let me take a driver's test, and if I pass, then let me drive. And I always think that the ADLs and the IDLs, somebody can cook a meal on one day, but they may not be able to cook for themselves. So do you know anything about the reliability of the test where they may have a good day and be able to drive, but that may not be actually representative of their driving skills?
Yeah, excellent point, and you're absolutely right. When we're looking at something that fluctuates, you could have a great day, and great, you passed your test on that day. As far as I know, thank you for just shaking your head, not reliable evidence, or that has been looked at in any sort of thorough way, but absolutely causes for concern and question, right? And this is, again, why this case is such a challenging one that we never really like to see. But excellent question, and it'd be nice to have reliable.
So there's no great data. I think there's so many reasons not to be able to drive that it's hard to get a homogeneous cohort, right? So it can be physical, it can be cognition, it can be medical problems. So that's really what makes it challenging to really pinpoint, when are you safe, when are you not safe. So the evidence really is just not there.
Excellent.
So my question is about the anaphylaxis case. So could you just run over the math a little bit more? So in my mind, if 98% of people with a penicillin allergy do not actually have it, then your pretest probability is only 98% is going to be negative. But your PEN score, if you score 2 or less, then it's 100%. So that's not that discriminatory above 98%. And then if it's 3, it's 94%, which actually increases their likelihood from baseline. So why is your cutoff not 3 instead of 2? And is that math correct?
Yeah, so I won't be able to go over the math on the stage right now. However, I have better than math. There is an RCT that was just published, maybe, I don't know, a couple weeks ago, in one of the JAMA papers, the PALIS RCT, pretty cool name too. And what they did is they randomized about 400 patients. So they were all low risk. I believe they used less than 3, but the bulk of the patients were 0, 1. So you're really looking at patients who had a rash as a child, they don't remember, they may have gone to their GP, but that's pretty much it, right? They were either randomized to an oral challenge right away, or to do a skin test and then do an oral challenge. And then the 2 groups were shown to be, so the oral challenge was non-inferior to having the skin test first. So I think people are not particularly comfortable just going ahead and giving a full dose of Amox, for example, and we'd rather do the oral challenge. And the data as we have is that it's probably just safe to do. You don't need to go through a skin test.
I don't see people like lining up for questions. If anyone has places to be, we have 10 more minutes on this stage, and you know we can't turn that away. So we're going to do another case, if that's okay, and we'll pick the highest voted cases. Oh, there is a question. Just kidding. Never mind.
It's more of a broad question. I work a little bit more in a hospital, and so when I think about sleeping medications like the Z drugs, in my experience, like half of the people will have a delirious episode overnight, and they always say the same thing. Do you have any like evidence or suggestions to offer on approaching that in like a hospital setting when a person is acutely unwell but not sleeping for days in hospital? If there's anything more safe or less safe?
So I guess all I can really say is the evidence that we looked at was surprisingly okay about Z drugs, and you're speaking of your individual experiences that connect those. I don't have specific evidence on hospital patients and insomnia. So these are more general population. So I don't have a specific answer to that question. Okay. So we are going to do another. We're doing it. We're doing a case. Okay. So we're going to vote between either Ken Doucette, or we're not going to do Mr. Ramakanta because that is a long one and we'll definitely go over, but she speaks quickly, so she could get through Ken, or Farah Lowe, because those were relatively high popular. So Ken, who's voting for Ken? Okay, and who's voting for Farah Lowe, heavy menstrual bleeding? I think it's Farah. Okay, so Farah is somebody who was also returned. She came to you earlier with fatigue that turned out to be anemia, and she has anemia which is 103 is her hemoglobin, and her MCV is 77. So she has a microcytic anemia, and she started taking ferrous gluconate 2 weeks ago. Must say I'm starting to feel a bit more energy taking this iron, but I've got my period now, and man, I am going through a super tampon every few hours. I can't take it anymore. I've had to miss work, and I haven't been able to work the last 2 days, and this is a really common pattern for me. So, from before, you note that Farah has no remarkable past medical history and no family history of celiac disease, colon cancer, GI disorders. Her TSH is normal. You ask her, has she had any other unexpected bleeding? Does your family have a bleeding disorder? No, haven't noticed anything, and I don't know of anything in my family. Her blood pressure 104 on 62, and the heart rate's 72. So she's hemodynamically stable. So, what testing would be indicated at this point? Von Willebrand factor and antigen, ultrasound, nothing. So, nothing. Von Willebrand disease, the prevalence in women with menorrhagia is about 10 to 18%. But the disease is usually associated with other unusual bruising and bleeding. It's hard to diagnose. It relies on a combination of clinical features, and you have to check for the antigen, the functional activity, or factor VIII assay. These serum markers, surprisingly, they fluctuate within the same woman at different phases of the menstrual cycle. Very limited data exists around desmopressin, and the reason I looked into this was just because that's what you would use for von Willebrand's disease, and 2 other treatments for menorrhagia. But there was one single RCT that showed a better reduction of menstrual blood loss with TXA, or tranexamic acid, compared to desmopressin, indicating that the von Willebrand disease-specific therapy did worse than another more general therapy around reduction of bleeding. Trials that examine treatment for menorrhagia, the ones that we've looked at, they don't routinely check for it. And given its prevalence of 10 to 18%, one can presume that these women are represented in these trials that are looking at the effectiveness of the various therapies that I'll be going over in the next few minutes. So with regards to the ultrasound, the SOGC says that if imaging is indicated, of course, a transvaginal ultrasound would be the first line imaging, but and then the indications for imaging would be suspicion of uterine fibroids. That's unlikely in a 27-year-old. Adenomyosis, endometrial polyps, or uterine atrial venous malformation. So we have done Farah's Pap test, and it was normal, and there was no evidence of endometrial endocervical polyp in any case. So you're talking about her period right now. Sounds really bad. We should have a look at helping you right now with this particular heavy period. And yes, please. So for right now, for this very heavy period, what's an option that we can use for her to try to slow down the bleeding that's happening right now? TXA, tranexamic acid, 1 gram TID for 5 days. Monophasic oral contraceptives, Q6H, till bleeding stops and then taper. Medroxyprogesterone, 10 milligrams Q4H, till bleeding stops, then taper. NSAIDs, either ibuprofen, naproxen, mefenamic acid, or IV conjugated estrogen, 25 Q4 to 6H, for 24 hours. So the first 4 are options, and some better than others, as we'll see. But the IV conjugated estrogen we'll go through the teaching points here. So TXA, usually 3 to 4 grams per day, reduces clinically detected blood loss and sanitary items used compared to the placebo. It is superior to oral progesterone or anti-inflammatories in reducing detectable blood loss. And various doses, so my next slide has more. So the side effects of TXA, there is no difference compared to placebo. And when they looked in the large TXA trials that were in trauma, there was no increase in thromboembolic events. So it should be avoided in people with a history of thromboembolic disease, or event rather, but it isn't associated in the general population with increased bleeding risk. So, or their clotting risk. So back to the various doses of oral contraceptives. Sorry, that bullet should have been on the next slide. So those recipes for the high dose estrogen or progesterone, those have not been evaluated in a systematic fashion, one against the other. And so these recipes that I've listed there are based on expert opinion and have been used to be shown to be effective, but that specific recipe is one that doesn't have strong evidence behind it. So the side effects of high-dose contraceptions are primarily nausea, and there is a theoretical risk for thrombosis, so you should keep an eye for unilateral limb swelling if you are using that protocol. NSAIDs, they can reduce relative mean menstrual blood loss by about 30%, fewer sanitary pads. Those are some of the regimes that have been used. It's typically used at onset and during menses. So given that her vital signs are stable, she doesn't need to be sent to the Emerge for IV estrogen. So that sounds like a plan for now, but how do I prevent it from happening again and again? You're right, there are a few options. Were you looking to conceive anytime soon? Nope, not planning for a few years. So place the following in order of effectiveness for longer-term management of menorrhagia. TXA, IUD containing levonorgestrel, NSAIDs with menses, combined oral contraceptives, long-cycle progesterone, so progesterone from day 5 to 26. Like medroxyprogesterone is usually used. So the one that comes out on top is levonorgestrel containing IUD. Then TXA and long-cycle progesterone are about similar. NSAIDs and combined oral contraceptives. So the levonorgestrel containing IUDs, compared to other treatments, their blood loss is reduced 80% versus 25%. More women with an IUD are satisfied, and more remain on treatment at 2 years. So looking at the comparative comparisons there in terms of mean blood loss, the IUDs minus 105 mils, antifibrinolytics 80 about 80 mils per cycle less, and NSAIDs about 40 mils per cycle less. And interestingly, combined oral contraceptives, no real difference. Perception of improvement, no certain superiority. So she says, I think I'm leading towards the IUD once this cycle settles down. So you make a plan. Right now, she'd like some TXA, and you've prescribed 1 gram TID for 5 days. Continue ferrous gluconate, give her prescription for the IUD, and plan to follow up in 2 weeks. And have her connect with your office if the bleeding worsens, does not improve, or go to the ER if she starts to feel lightheaded. And it is 4 seconds left. So we got in under the wire. So thanks very much. And if you have questions you're welcome to, we'll be here for a few minutes afterwards if you wanted to come and ask us questions. But thanks for your attention. Have a good day. Okay.